Hi there, I'm the neuromuscular mechanic, and today we're going to be talking about ultrasound-guided chemodenervation of posterior calf muscles. So the muscles we'll be looking at will be the medial and lateral gastrocnemius and the soleus that make up the triceps surae, as well as the tibialis posterior. Today there's going to be no discussion about the flexor digitorum longus or the flexor hallucis longus, which are covered in a separate video series. So the one disclaimer I have is the muscles that you'll see today on video are from myself, so they have normal echo texture. Keep in mind that individuals with spasticity often have increased echogenicity to their muscles, so it can sometimes be difficult to appreciate the borders of individual muscles. That's where it's important to use your landmarks to identify relevant muscles, and keep in mind the importance of potentially adding electrical stimulation to your ultrasound guidance. So the first series we'll start with is the triceps surae. So if you start with your ultrasound in short axis, just inferior to the popliteal fossa, and what I want you to identify is the fascial plane that separates the three muscles of the triceps surae. This is a perfect starting point. So here we are here, and if I pause, there's that fascial plane that separates on the left the MG or the medial gastrocnemius from on the right the LG or the lateral gastrocnemius, and then the soleus underneath. So this is the starting point. So what I'm going to do here is I'm going to move the probe over laterally here, just in a second there, and now I'm going to move distally and pause. So there's the lateral gastrocnemius. This would be an ideal spot to potentially inject. In a second here, I'm going to move even more distally, and you see that the lateral gastrocnemius will taper, become very thin, and the soleus will become more apparent. So again, this is a great spot to inject. What you'll appreciate in a second as I go over to the medial gastrocnemius is at the same level of the calf, the medial gastrocnemius is much thicker than the lateral gastrocnemius, which means that laterally the soleus is potentially easier to target. So you'll see here, I move it over medially, and there's the medial gastrocnemius, much thicker than the lateral gastrocnemius at the same level of the calf. So again, here's a great spot to inject the medial gastrocnemius. And now I'm going to move the probe more proximally up towards the popliteal fossa, back to that home base at the fascial plane area there. So with the dosages, if we look at the product monograph, the gastrocs will be for Dysport 100 to 150 units for the lateral or medial gastroc, and then for Botox 75 units. When we look at the soleus for Dysport, we're looking at 330 to 500 units. And when we look at Botox, we're looking at 75 units. So the next muscle, the last one we'll look at, is the tibialis posterior. So to identify it, take your probe, put it in short axis, about distal third of the calf, such that the probe is over the anterior medial aspect of the tibia. And at this area, what you'll identify is the overlying soleus, then the FDL, which are both superficial to the tibialis posterior. So here we go. So we're just going to pause here. So on the left, we have the soleus. On the right, the bony contours of the posterior medial aspect of the tibia. And then we have the flexor digitorum longus. Now what I'm going to do soon is I'm going to start flexing my toes. So here I am sort of flexing my toes here. And you can see the FDL, the border there. Deep to that will be our TP or our tibialis posterior. Again, sometimes it's very difficult, not only with the echogenicity of the muscle, but just with the depth to appreciate it. Now, there's many views to look at the tibialis posterior. You can look at it anteriorly through the tibialis anterior or posteriorly, but this is the view that I prefer for chemodenervation because the muscle is most superficial. So what I'm doing here is now I'm inverting, and you can see the tibialis posterior sort of being activated. And this is where I'd use electrical stim. Now the dosage with the product monograph with the tib post would be Dysport 200 to 300 units, and then Botox 75 units. And again, it's quite a deep muscle. It's not always apparent on ultrasound. So again, the importance of electrical stimulation. So that concludes my videos. I'm the neuromuscular mechanic, and I hope you found today's video handy. Take care.